another pathway for primary care patients to receive much-needed intervention in a non-threatening way within the context of their medical appointment. Prior to this project, our behavioral medicine services weren't routinely provided within the general flow of the primary care setting. With respect to our target population, if somebody can move the slide to the one that says the majority of consumers have co-occurring disorders, that would be great. As I mentioned before, our patients are diverse, but we really focused on finding common themes among them, such as being dually diagnosed with respect to mental health and substance abuse disorders and multiple medical issues. And given our overall need, our question was, how do we focus the resources that we have? And we really decided to target patients' challenges with adherence, their barriers to self-care, which we were hoping would have a positive ripple effect across the continuum of care. Our thinking was if these challenges were present in one appointment, likely affects others. And we found that adherence issues are influenced by this perceived stigma of mental health treatment. Often our patients can have multiple services in one day because of their special needs, and that really impairs follow-up. So our current BMed project really tested the utility of brief screenings, assessments, which was primarily identifying the patient's stage of change to inform whether or not the intervention needed to be educational or action-oriented. And interventions with the primary care patients occurred immediately following the medical appointment. And this was not to replace our traditional mental health services, but certainly to supplement them with the goal to be more fully integrated as time goes on. Our behavioral medicine providers were introduced to the primary care patients as a consultant who are available for education and intervention. And we were pleased to find that the patient's primary care physician was a good starting point, and their relationship with the patient likely transferred to the perception of the behavioral medicine provider because all patients asked agreed to the consultation. If we can just move to the slide that says opportunities, that would be great. And really we found that small steps contributed to considerable gains. We started to integrate more at the administrative level, such as at meetings, and use that information to determine the best point of entry of introduction of our services. We're a large system, and that certainly has its benefits, but also its challenges in terms of integration of care. And we are located in separate buildings just right around the corner. So we really needed to learn what medical was doing, and they needed to learn how we could help them. So we shadowed them, spoke with them following appointments to see how we might have been helpful for that patient. Primary care office space is an issue since we've grown rapidly. So our BMed provider had a separate office right in close